issues with anything, please unmute yourself or write in the chat as well if you have any other comments or feedback for us.
Okay, so let's look at it for the sake of the 1% of our colleagues who thought this 1+. Let's have a quick look at the H&E because it's very important for us to see the morphology and the preservation in particular.
Always.
So this looks like a high grade, no tubule formations from what I can see. The cell's not very large, but they look quite hyperchromatic and pleomorphic.
Quite ugly as well. I spotted a few mitosis already.
Yeah. So it should be a fairly easy one.
And the majority did say 92%. They've said 0.
You can see our cell line controls that you are already probably very used to them. And we can see that more and more people started using them. So this is our 3+. You can see circumferential staining with strong intensity. We're using the magnification rule. Now the second core should be, we should be able to see, I need to move this a little bit. Staining at 10 times magnification. I think this is fairly a bit
weak than we would expect usually. Yes.
But it's interesting, just like with the RNPR, we see stronger staining in the, now this is cut off. This is not a very good example of 1+, but we do see staining at 20. And then the last core should be completely negative. Sometimes we see a little bit of cytoplasmic blush or a very low proportion of membrane staining, like you see here. So let's get back to the tissue. Not too much. We're a bit too far still. This would be 5 times magnification. Maybe we see a little bit of blush, but we don't know whether it's membrane or not. What do you think?
For me, at this magnification, I think it's quite negative. Like you said, we kind of see here a little bit of, where is it here? A little bit of blush, cytoplasmic blush. However, the people that did say 1+, we need to think about what 1+ means. That means 10% of the cells. So
Exactly.
even if we have now and then a line, which to be fair, so far I'm not seeing any lines, but even if there is a weak staining or moderate staining intensity line, we would still call a 0, maybe with a comment, and we are going into the subtype of ultra low. But we need a 10%.
Yeah, and this is pigment, if anything. So yeah, the other core, I think, is completely negative. So it's no convincing, basically, membrane staining. So would you call this null, maybe?
Yes, I would say null. Now, again, as we talked about, because this is digital, everything depends on everyone's computers, but usually it's the other way around. People that are seeing lines, some people are not seeing those lines. So we should not look, let's find lines when there are none.
We tend to overcall it rather than undercall, especially with the 1+ or HER2 low development. So now we're on case 2. Here the battle is between 1+ and 2+.
And look, even the panel diagnosis,
it's the same.
It's not full concordant.
Divided. So this is case
175.
175. Great. So quick look at the H&E, because I think we need to make a point about that, right? Because we need to make sure we understand how the tumor looks like. Always. Sometimes it's crushed, sometimes it's poorly preserved. This is slightly probably lower grade, more like intermediate type carcinoma, but again, not much tubule formation, probably a grade 2. So not a grade 3. That's also important when looking at HER2. Now someone highlighted the cores because they're a bit pale. But if we go by the magnification rule and look at ×5, what do you think?
You can see lines.
We definitely see lines. How much? Quite a bit. I mean, they're spread along the tissue, along the tumor. And then, of course, we need to go a higher, this probably is in situ here, but we need to go a higher power to kind of confirm that what we're seeing is, they're quite thick, aren't they?
Over
A
there,
bit,
yes.
a bit unusual in that respect. So if we look carefully, they look as if they're stronger on the outside of each cluster, although you see around the individual cells as well. So this kind of falls into that category that we like and is kind of ignored, isn't it?
I think, yes. I think the people that did score a 2+, and they were 15%, and probably also a few people from our panel diagnosis, because these lines, you can see them at ×5. So that means they are strong intensity lines. You can say this is an indeterminate result, and I prefer to reflect that to ISH. Like Adelina also mentioned, this is not a high-grade tumor. Are we expecting this to be DDISH amplified?
No.
Don't think so. We might have surprises. We did have surprises in the past. I think the people that call it a 2+ were cautious. If I would have had this case, I think I would call it a 2+ on the basis that I have seen those strong lines over there. On the basis that most the people score it 1+, I can see why again. If you're going a magnification of 10, you have lines over there. You can see them, so they're at least moderate, and they're more than 10%. But the problem is you also kind of see lines at low
5.
magnification.
Yeah, and that's you want to be cautious, because what if your immunohistochemistry didn't work for whatever reason, and then you have something that signals you that there could be amplification there.
However, the DDISH in this case, as far as I know, was not amplified. So the people that call it 1+, clinically wise, wasn't a mistake. So all good in the end. But we need to keep this in mind that there are some cases that look like this, and in the end they are DDISH positive, DDISH amplified.
Yeah, so this strong, although incomplete membrane staining, we need to keep it in mind and to be very cautious about it. Now, let's go for the next case, which is again the same battle between 1+ and 2+, and almost 5% of people even call it 3+. There's a non-evaluable kind of bunch here. So let's have a look at it.
If there are people that said non-evaluable, I'll be curious if they want to put in the group chat or even unmute themselves to say their reason. It will be really interesting to hear, because they might be right.
Yeah, it's not a bad thing to say when it's the case. So this looks quite apocrine in morphology. So we need to be a bit careful with these cases, because sometimes they can have funny staining. Let's have a look at the HER2.
But this time the panel diagnosis had concordance 100%. So that's good. I can see why. Okay.
So we see staining, but let's see if we see any lines though. I mean, here is not very clear. I'm at 5, right? Let's go again for this score. I mean, maybe yes. Not very sure.
I'm not convinced though. I'm really not convinced. Let's go a little bit high power.
10? Yeah, definitely see.
At 10 I can see lines.
So this is rather kind of moderate, or maybe it confirms these few cells that I've seen at 5 times magnification, but this is more moderate staining. And if we go a higher power to see what's going on in effect, we have this granular cytoplasmic staining that is variable, but even strong intensity, which is associated with this morphology, actually, of apocrine carcinoma. Let's see the other one. So in this case, this is a bit more tricky. I think I would score anything that has this granular staining that makes interpretation difficult, that also has membrane. I will score it as 2+. Now it's moderate. The staining doesn't quite.
So in the end, this is an aberrant staining, so we should not
Yeah.
score it per se. And especially, you know, when we were talking about these 1+ patterns and what to score and what not to score, these kind of blob-wise and cytoplasmic staining and granular part of staining, we should not score it. But now the question is there also real membrane staining that is hidden? Although, like you said, this bit here, even if we ignore this, you have these lines here,
Yeah.
which they are quite circumferential, and we can see them at times 10, are we?
Yeah.
Yes, we can see them at times 10. So it is moderate. So on this balance of moderate and complete, it is a 2+. Also, some people would also see it. We weren't that convinced from here if it's real strong staining intensity, but how this overall case looks like, yes, I think it will be sensible to call a 2+. In the end, Tidish was negative, not amplified. So here, the people that in the end call it a 1+, they didn't go wrong with the diagnosis, so it wasn't a positive one. However, the ones that said positive 3+, I think we should try and review this because this is not a 3+ staining. And like Ade said earlier, always compare it with your controls.
The other thing is that this cytoplasmic staining kind of obscures the membrane staining. So when you're low magnification, especially because the cells are very small at that magnification, then it prevents you. Because if I go here, higher power, some of this is strong, but you don't actually see it when I go to 5x. So I think the cautious side is not. Plus, these cases are not very common. So if you throw a niche on these cases, you're better off than missing membrane staining.
Did anyone say in the comment or something about the non-evaluable?
Should we go for the next one if no one has any questions?
We are flying through them, as you could see.
We're going too fast, people. You need to.
No worries, at Didish, we can talk, we can count and count. It's okay. We love counting.
Okay, so
let's see.
Again, 1+, 2+, which is
Indeterminate 2+.
You know, if the case ends up being amplified, there is a problem. If not.
Do you remember, I think in our educational session, it must have been a slide over there where it was the algorithm, the interpretation algorithm with the magnification rule integrated. And it was saying very nicely, you start at low power times 5. Do you see lines? If yes, are they complete or incomplete? Incomplete. So you don't see everywhere nice, strong lines, because otherwise it's a 3+, beautiful. If you see lines and they are incomplete, that's a Didish case. If you don't see lines at times 5, then you go times 5, times 10, and again, do you see lines? Are they complete? Now, if they are complete, that's beautiful. That's again a Didish. If they are incomplete, then we are going into the 1+ category. So if you keep these things in mind, and it's when you look at that ramification and that algorithm, you think, oh, another algorithm. It's not that difficult. I mean, it's not that tricky to understand it and to make it your own and to have these steps in your mind when you're looking at any HER2 case. And I do think once you take it upon you, then it's way much easier almost at every single case if you're more methodically, okay, how I'm doing here. And again, we always have Didish or Fish that can give us a hand.
Yeah, except for the low category, unfortunately. And we're going to have actually, this one is the interesting case, I think.
Okay, let's see.
Or the next one?
I have no idea.
Okay, so this one, like I said again, but we also have some people saying 3+ again, the same proportion of people. So let's have a look at it because it sounds interesting. So this is the next one?
183. Yeah.
All right. So let's see what kind of case we have. Does it look like a negative? Again, that kind of low grade, grade 1 to 2, maybe a few tubules here, maybe one mitosis. Not the ugliest carcinoma for sure. Yeah, it looks more like a grade 2 ductal. Oh, we already see color. We're not even at
I'm trying
5.
to focus on the 3+ people now. Why this would be a 3+? You see lines, yes. Are they complete?
By no means. And even at this magnification, you can say that there must be a little bit of cytoplasmic as well. But the membrane staining is, first of all, a low proportion. It is over 10% for sure that we see, but definitely, I can't see a complete cell, I think. Not even one.
Nope.
Maybe here, this is inside too.
Exactly. I don't even know if that's real invasive.
So it is indeed membrane staining.
Yeah.
Not even at this magnification, circumferential, and I'm at 20, over 20. So if I go to 10,
But
definitely.
again, even if you have 1 cell, 2 cells, we still need the threshold of 10%.
We need a proportion, and be careful because ultra low category, even if you see moderate staining, if the proportion is below 10%, this is a rare pattern kind of, because once you see moderate, it's usually 1+.
Yes, exactly.
You usually have the proportion, but you need to be careful to pay attention to proportion of tumor cell staining. So yeah, this is a beautiful 2+.
If these lines, you wouldn't see them at ×5, I would completely agree this is a 1+. We have a question. It is not predominantly basal staining than basolateral and lateral. Majority of the cells showing complete membrane staining.
Agree. Yeah.
Yeah, true. I do not know with Adelina's mouse. Apologize. True. On ×5. On ×5, yeah, you can see lines now. You can see lines, but you don't know exactly where those lines are because at ×5 it's just too low power to realize. Then you put ×10, and now you can see also inside here and here and here. And then you can put even ×20, and you can see even more lines, and you realize that this is real staining that also goes inside those cells.
But I understand the point, because it looks like the stronger staining, or what we were seeing, is mostly at the periphery. So this could be an argument for some people to just go for 1+ on this case and say, oh, maybe this is basement membrane pattern and it looks stronger. Okay, I have true membrane staining, but this is at most moderate. If we look inside and I don't know actually,
Look here, this is a perfect one.
Yeah.
If you put 5,
so you see, we also have inside, this will be strong, this will be visible. So we see it. And here as well.
Completely agree with predominantly you have more on the periphery, but then you also have inside.
And then you can say, well, but this is less than 10% that is inside. You can carry on with this kind of judgment over the case, but I think would be more cautious, because how do I know that actually the rest of the tumor could have stained like this? Is there a gradient here? Is this less this area, for instance?
Yeah, might be.
So it's kind of difficult to understand for sure. Once you see strong staining, I will be very cautious.
I think that's the rule of thumb.
If I see 2 or 3 cells, that's fine. I can just go with 1+. But this is quite a big of a proportion for that. So
yes,
I think that's you had a very nice case recently, and I think you show it during the educational session, right?
The same.
Where it was kind of this pattern. It was more like moderate to strong, not
moderate
even
to strong, and it was quite weak, not that strong. And I did say it, if you're going to review the DDISH educational session, we showed a case that very few lines at ×5, like in more bad days, probably I would have let it go, very few. And then the only thing that made me put DDISH was those very few lines and the fact that the carcinoma was also ER negative, PR negative. And I really wanted to exclude the HER2 positive subtype. And I had also the strong lines, so I caught those strong lines and I said, I'm seeing strong lines. I prefer calling it indeterminate, and I reflex to ish. And then on ish, I had small amplification clusters everywhere. So yes, and then it's again a preservation matter and so on. Strong lines at times 5, I think it's best to be cautious and call it indeterminate and to reflex.
But the good point about the basement membrane staining.
Yes, that's true.
All right, this is all distributed. We have 0, 12%, -1 plus most of the people, and then also 2 plus. So
But we don't have 3 this time. We don't have 3 plus.
That's good. So something must be very difficult, very complicated.
I
That's
think this is what
190.
we need to be cautious, not to call 3 plus when it's not a 3 plus. If you're not that sure, now if you're calling it, it is a 1 plus, and you're calling it a 2 plus, you're not doing anything wrong here. You're just spending more money and more time to prove it, and it will be not amplified. But if you're calling it a 3 plus and it was not, then it's no
Yeah, there's
return
no way
point.
you're going to find out. And I guess we need to make sure that we are aware of the reasons why, for instance, staining would have heterogeneity in the 3 plus kind of array, because in breast cancer we usually have wall-to-wall, diffusely positive, strong, circumferential. Now, when you have necrosis, when you have poor preservation in one side or another of the tumor, you might see, okay, this is fading or is almost negative. I had cases where, including adjacent to the necrotic areas, so tumor cells that looked preserved, they were negative for HER2, but only around the necrotic area. And then you can have tumors that have two morphologies, and that's when you usually have HER2 positive component, HER2 negative component. But usually breast cancer, especially when you have a uniform morphology, it's not. If you have heterogeneity of the staining and it's not quite 3 plus, then you are a bit in trouble if you just go for 3 plus, like Simona was saying.
Yeah, 3
Don't
plus
just
needs to
go.
be a 3 plus by the book. I wouldn't call anything else, and always compare with your control. Now, if you have cell lines, that's perfect. If you have, your best, oh bless them, we have a crying child on the street. If you can hear it, it's not, we didn't make him cry. We know they're using a positive tumor as their control, and they know that tumor is positive. Whenever they are asking us to do a DDISH, for example, and I'm looking at their HER2 and I would think, I would not call this a 2 plus, but then I'm looking at their their external control, so on slide control, and I'm realizing the 3 plus is not even a 3 plus that I would call a 3 plus. Then I understand that pathologist is used with that antibody. He knows when to call a 2 plus, he knows upon their rule, more or less. And then I'm not the one, sometimes I've repeated, and then it's completely different to HER2 because I repeat it in the moment that they said it, they send the DDISH for us. Trust me that HER2 was a 1 plus, very kindly given a 1 plus, but then my DDISH was amplification clusters from A to Z. I repeated the HER2 in-house and it was a proper 2 plus. So now depends on the antibody. I'm not that sure what kind of antibody that laboratory used, the clone, antibody clone and machine-wise and everything.
Yeah.
So if a pathologist in the end, it's used with their in-house clone and they know how to interpret, then
yeah, the problem is it's very difficult when you do these cores from tumor because again, you can have areas of weaker staining. Then you think, oh, it actually could have worked, but your positive tumor is not that positive. Then especially around HER2 low 1 plus, it's very difficult to find the control, especially that keeps the uniformity of the staining in a way that it helps you. And then you don't know what the rest of the tumor shows as you go deeper in the core. It's not like with cell lines when you have a control expression of the antibody.
That's why we really advocate for the cell lines. You have the nice gradient and you know what to expect and always compare it with it. Okay, let's do
next case. I put them side by side because this is a kind of a complicated case of my nightmares, I would say. So this was a sclerosed lesion. So this is kind of a tricky case, and they did mention it in the histopathology report. This area shows mostly in situ tumor. So all these are my epithelial cells. So here we definitely have a 1+ expression. If we go, I'm at 19 magnification. Now, some people call it 2+, so we might want to take a step back. I do see some staining. I'm not very sure. I see definite lines, at least not in a high proportion of
But if
tumor
this
cells.
is in situ, why are you looking at in situ?
I'm just thinking that, this might have been interpreted because otherwise, I think if they looked at the invasive, because for instance, the invasive is here. So in the invasive, the question is it 0? Is it 1+?
It's a hunting game.
This is a hunting game. So this is your in situ. That's where you see staining at low power. And this is your invasive and mixed, which looks kind of lower grade than the in situ, which looks more like intermediate DCIS, but regardless of that. So it's kind of just trying to look at the invasive. This, by the way, is all detached. All this could be from the DCIS, most likely, because the DCIS is chunky. So make sure you don't interpret this attached to the core as your invasive. This is your invasive. Now, this is very difficult to understand. I think I'm already at almost 40 magnification. Is this membrane staining? I think we had better area, actually. This is again inside to, where do we have more invasive?
Maybe on the other core.
So there is some staining.
Cytoplasmic wise.
But it's very, yeah. You wonder if this was better preserved. Would have I seen, let's say, better membrane staining in the invasive? This to me again, this is the same area as this on the left side. So this is in situ. This, talking about the pattern, I think is the same. It's so difficult to distinguish the invasive component from this again. Is this cytoplasmic with a little bit of condensation?
You're already at 41. I think that's cytoplasmic, yes.
Again, very difficult. I think there was an area in the corner that I thought, oh, maybe this is membrane staining here, I think. But again,
arguable.
Difficult. What do you think? It's a bit fuzzy, a bit.
If this is invasive, real, and not in situ, like you showed the other one, you might say that this is, but still you would be at a 0 ultra low wise. Yeah, not quite. This is still cytoplasmic.
Cyto. Then you have more DCIS. So
yeah, but this again, you don't quite see any membrane wise.
I think the idea here is to make sure you understand which bit is your invasive and which bit is in situ. And you can have complex cases like this one, which is a lot of sclerosed. You also have more normal looking lobules with invasive, with the DCIS.
Like this one, maybe here.
Yeah, this one.
We were
again. We were looking last night with Corrado, and he was still convinced that this is in situ. So
it will be useful. It's very difficult. My epithelial staining here.
Yeah.
However, good. There is no 3+. Good. The people that scored it at 2+, most probably they scored also the in situ component that looks quite sclerosed, and probably without my epithelial marker here, some would have thought, oh, this is all invasive. Still, I'm not sure about the 2+, because I don't know if we even seen lines of ×5 over there.
Yeah.
So that's, but again, DDish not amplified, so on, so not a big mistake. Probably if we would have scored all this light from A to Z, would have been a 1 plus because you have staining. Now, like Ade said, invasive, non-invasive, a myoepithelial marker would have been very useful. We can distinguish side by side then, and we can, in the area that really looks invasive, probably, yes, it's more cytoplasmic and it's more towards a 0.
But you
Or an
definitely
ultra
see patterns, and then you start understanding, oh, actually, this is in situ merging into or being super sclerosed. So, yeah.
It is a tricky case, a very tricky case indeed, this one. So nobody holds the absolutely truth, not even us. Especially not us. So yeah, it is a complex case. You need more help with other IHC stains, I would think. And the brilliant threshold of 10%.
Which is not very useful, especially when you're trying to assess the whole tumor. Most of the time, I mean, many times we go back, sometimes we go to the excision and then we realize, oh, we were between 0 and 1 plus, and this is definitely 1 plus.
It's also the amount of tissue available for assessment, definitely. So, and again, because what is the distinction between the two? It's a threshold of number of 10%. So as more tumor you have, yes, you can play more with this threshold, how many cells you have. If it's 0, if it's null, it's fine. But then if you're starting seeing even a few lines and you're already going on biopsy on ultra low, you might expect on the excision to be 1 plus, definitely.
Yeah. When you start seeing expression, then it's possibly no limit. So, okay, last HER2 case?
I think so. Yeah, I don't have another page here.
Okay, so this one negative, almost 20%, the rest 1 plus, and a few of you said even 2 plus. Again.
2 plus rules, either strong intensity times 5, less than 10% and incomplete, or times 10, moderate staining intensity complete. So that is for the 2 plus. And now I'm looking for Ed to show me the IHC, the HER2, and let's see.
But I would be bored of HEs.
Really curious for the people to try and tell their thoughts and to tell us, whoever, look, I scored this a 2 plus because I thought like this. That would be brilliant.
Yeah. I don't think I've seen the IC for this one, but I just want to draw your attention to one element. So sometimes in high-grade carcinomas, we have these abortive lumens that are less, let's say, easy to see compared to your tubular typical carcinoma. And they sometimes show staining in this kind of secretion or very apical staining. So we need to make sure that we're not scoring that at the moment. Because we don't know what the future holds. Who knows? But this is high grade and a bit apocrinish maybe. Okay. So low power, not sure. We see a little bit of color, but I'm not sure we definitely don't see membrane staining, but there's something in the cells here.
So now one more shot for the 2 plus. It's times 10, complete membrane staining, more than 10%.
So negative. I'm sorry, we can't support those who said 2 plus at the moment. This is even less. So here I'm struggling to see any color, whether it's cytoplasmic or membrane.
We're starting seeing some membrane.
We do see lines at 20 magnification. Yeah. So that means it's something weak, maybe even not really moderate, because we don't see very clear. How about this area?
It was more optimistic. Yes, you can start seeing lines.
With this cytoplasmic though, but this is 40.
Yes, but this is for confirmation wise, and I think you kind of are starting seeing some lines now and then. And if you're starting looking here, I think this would be a 1 plus case.
Yeah,
it will be more than 10%. And again, they are incomplete lines. So in the moment that you're seeing a line, that's a line over there. Now the question, how are you calculating that line? It's one cell or two cells? That's another story. But point being, okay, people that put 2+, that's fine. Again, it will be a non-amplified case, a little bit more work for the team, a little bit more work for the pathologist to report. Nobody call it a 3+, but again, I really am stressing this out, why the criteria for a 2+. It's okay to call it a 2+ when it is a 2+, or when we have our doubts. But then that's why I always say, look at our own slide control, because we have the own slide control. If you're used in your laboratory with a different clone and a case like this, you would have called it a 2+, because you're used with your controls and everything. Yes, okay. And maybe those cases even might be D-dish amplified. But in these kind of cases where we're dealing with 4B5 and we have the on-slide controls and everything, compared with the controls. And I think I'm talking too much.
No, that's okay. Okay, so yeah, it's very helpful to have adequate controls. It can help you even learn. And we've seen some improvement in people who use cell line controls. So yeah, that's very important.
Any questions for the HER2? If not, we are going to start the D-dish, where we need to count. We still have 20 minutes to go. We'll finish in
Can
time.
you make a point of just looking at the cells and not count very much?
Not count to the point.
I think that's the thing I hate the most.
Yes, we are not going to count. We refused to count this circulation. We just looked at, although we did say when we reviewed the cases, and we are going to make some comments for them, that doesn't matter in the end at some cases. And let's take case by case, but yeah, we are not going to count. This is going to be educational session when we protest against counting. Let's see the first case.
Okay, so most people thought not amplified. This looks quite straightforward, although some gave amplification, some said non-evaluable for we don't know which reasons.
Okay, cool.
Okay, let me first find them. So
I have no idea, Adelina. Here, more down, that's one. Click.
Okay,
46.
first one is 46. Are we looking at, should we skip the H&A?
Yeah, we're skipping the H&E.
Should we look at HER2?
No. But let's look at the HER2. Okay, ×5. Are we seeing lines? Can see lines now and then.
Yeah, interesting architecture though.
Yeah. And now you zoom in and you see even more lines, and some of them even complete and more than 10%.
So this is also unusual morphology. That's another point that we could make eventually. Okay, let's look at D-dish.
We're going to believe that they are all 2+s for good grounds.
Okay, this we need to go high power, unfortunately, to begin with. But that doesn't spare you from looking along the core at high power, which sometimes is harder work than with HER2. So we need to make sure that the whole tumor looks the same. What I can see is a lot of red here.
Exactly.
It kind of blinds me.
Exactly.
So I do see black signals as well, but the ratio is definitely below 2.
Yep. The ratio is never, ever going to be more than 2 in this kind of case when you have a sea of red signals. That means you need to have an even bigger sea of black signals. That means equal amplification clusters. In the moment that you do not see amplification clusters, when you have that many red signals, you're never going to make the ratio above 2. Now you're going to the second possibility how you can make this case positive is you need to have more than 6 signals of HER2 per cell. Pick any cell that you want. You are going to find now and then
Maybe
more than
1 or
6.
2. Yeah, or just 6 in this
But
case.
overall, if you're starting counting them, I do not think you're going to make the more than 6 per cell of 20 cells.
I'm sure if I try really hard, I'm going to make this, if you're just above 4, maybe, for HER2
And
signals.
indeed, I'm going to clinical advice. We have here people that comment and very pertinent comments. Very cellular and difficult to make out the cell membranes. Completely agree. Completely agree. That's why try your best. Look, this one, I can take this one. I can see the cells. 1, 2, 3. I'm stopping here. 1, 2, 3 black signals. I don't even care how many red because there are many. This one, good luck to me. 1, 2, 3, maybe 4. And now I'm going back to what Ade said. I don't know if I'm making more than 4. Probably I'm going to make more than 4, just a bit. Completely agree. This will be that group 4 category that we talked about in ASCO Cup. And people very kindly said here would call this group 4 workup. What does it say, this group 4? Because we are going to make a point on this case, because I think the other one, I don't know if it's another group 4, but it's going to be the same advice. It is here, check on resection, says. No. What are they saying now? Although ASCO Cup, it's a little bit more tricky where it says, do not repeat testing on the same sample.
That's
Now,
the wording, and it's not very well explained.
On the RC path, if you read the guidelines, they are saying the same thing. Do not repeat on the same sample, comma, or any other block of this patient. Do repeat on metastasis. Do repeat if on excision, for example, you have a different morphology. What this group 4 says, you are counting once, 20 cells, you're in group 4. You are counting another 20 cells, you're still in group 4, maybe even third time, so 60 cells in total. Then I'm giving it to my colleague. She's counting again and again. If you're still in group 4, stop counting.
Now with the multiple cells counted, this tradition is more like from the UK and is older. Now they say, okay, you can just keep to ask your colleague, because the reality is he's going to be the same person doing the same thing all over again for no actual use in reality.
It's going to be a matter of luck to make it positive. And again, these people are not true responders. So we need to be careful. But this case wouldn't be a positive no matter how many times you're going to count.
Yeah, absolutely.
Please unmute yourself if you want to interrupt.
Of course, make sure that all your parameters are in place. If you excise, for instance, I had recently a case which was grade 1. It had 2 different components. On the core biopsy, we reported it. And then on the excision, it was a grade 2 that ended up being amplified. So, of course, repeat on excision whenever you need to do it, if there are other reasons, except for a borderline not amplified result.
This is one of the best comments, exactly how ASCO Cup says, and also RC-Path, all these guidelines. This is again the same, really good. Check on resection, no longer. It was called the borderline not amplifying, recheck on, no. Now this is how it is recommended.
I don't think there are still pathologists who follow the old guidelines and they recommend retesting, but we learned that it's not really relevant. This looks controversial.
This will be the same one. That's why I wanted to make a point there. It's this, and it's very interesting. I would like to people who are 73 that are online now to tell us in a chat how many times they counted this case, just this case. One time and they call it negative or positive.
This one.
Yeah, this one.
Number 2.
Number 2. How many times did they count it? 1 or 2 times or 3 times? Who counted more than once? I will be really interested.
I opened the H&E, but I don't regret, because it has tubules. But if you look at the cells, they're not very nice. When you have mitosis, it's that kind of case that is, it tells you it's low grade, but in reality it isn't. HER2, we said we're not doing.
We are believing that it's a 2+. We talked about
I can
HER2.
easily believe that. So, okay, so this is one of those cases. To me, when I see this, I'm thinking this is difficult, because I always ask myself when I look at the case like this, we can see cells definitely that you pick up on them immediately because you're looking for amplification. And then you see definite cells that are amplified. Okay, they have a ratio over 2. maybe even 4 copies of HER2 per cell. Maybe not all of them. Some of them are 3 to 1 copies, but you definitely see. And now, question: do I have a amplified population and mix with and this is where it comes the idea of interpretation, because you can have the same morphology even, but we see that there are tubules with higher gray cells, maybe lower gray cells at the same time. And now how do you count it? RC-PAT says you need to pick up on the heterogeneity that is admixed. So you don't have 2 different components like we were discussing earlier, HER2 positive, HER2 negative, very well delineated from each other. And then you have this, and RC-PAT says you need to pick up on the amplified population and then do account for the amplified population and do account for non-amplified. Like, I don't see the point of doing account for the non-amplified population now.
It's not amplified.
But the idea is identify amplification, whatever that is, or however it presents. And now the question is,
this is the kind of case, again, that you're going to have a low level of amplification. And you can see the chromosome 17, it's very low. And then you have a minor amplification, a minor increase in the HER2. And you can see 4 or even 5 or HER2 and 2 chromosome 17 and so on. And that's why even when we are looking here, you have the average so small, so under. But then look at the HER2, 4.8. You are going into the group 4. This is a case where I'm telling you, if before you were in group 4, the second one I'm calling again, I'm group 4. The third one I'm calling and it is, positive. What am I doing? Am I calling directly positive? No, I'm giving to also calling. My colleague counts once negative, then I call it positive. You need to call it positive with a low level of amplification. The moment that one of the counts, it is amplified, that case is amplified. And that's why I asked you guys, how many times did you count? Because this case has been counted 8 times for 2 or 3 different pathologists. And in overall has been called amplified with low level of amplification. Yes, we have a comment. I'm struggling to see if the black dots are unique or a cluster. That's even more interesting, because if it is a cluster, then you can
there
call
are at least doublets, or we've seen quite a few. Like if you go
1,
higher,
2, 3, 4.
or here,
Yeah,
these are
that's
doublets.
Yeah.
So I'm not sure, maybe not, or at most 3 signals, but I think I've seen doublets. But you see,
Yes,
like
doublets.
Simona said, there are very few red dots. It's almost like some cells have monosomy. But in this case, I feel like the amplified cells are quite obvious. Sometimes we have much fewer amplified cells as opposed to other cases. I would think so.
Yes. So be careful with this group 4. It is painful, the group 4.
Yeah.
Good.
Okay.
Next one,
We hope
83.
these are easier. Okay. 86% not amplified.
So this should be a straightforward one. Let's see. Amplify 13.
That's 83, isn't it?
Yes, 83.
Should we go straight for D-dash? Do you think we can do this?
Yes. If we are struggling, or people would request to see the... Yeah, this is an area that did not work.
Yeah, be careful with those. Few signals, that's the first impression, isn't it? I mean, I've seen a cell or two with 3, 4 HER2, but the signals are not very many.
But look also the chromosome 17, that you don't have 1 or 2, you have 2 or 3. So in the moment that you have, look, that one, 3 and 2. A 3 and 2, it's always a non-amplified cell.
We don't have doublets, we don't have clusters, we don't have anything. Very few, 2, 3 per cell of each of them. So it will never make a positive ratio or
so overall here, the HER2 was 2.55, the average.
It would be interesting to know, why do we call this amplified? Why would anyone call this amplified?
We invite the people to unmute or to
it's quite a proportion of people thinking that.
ASCO-CAP group 5, yes, we agree. Total negative or very weak. Yes, we also kind of agree. It's not totally negative. It is weak, I would think.
Yeah.
And not the great scanning, unfortunately. Fish for confirmation. I wouldn't go there. And
I wouldn't think it's necessary.
Repeat the testing in the operative. No need. Unless you have, like
Maybe they were worried about the HER2 expression, or no?
It's fuzzy.
This
very
fuzzy
fuzzy.
is
It's a real
garland
2
like
plus.
dotty.
It's a real 2 plus. Yes, but it's very fuzzy.
Yeah, this wouldn't, I think, um, worry us too
Case
much.
number 4. Oh, this I would expect. Amplification clusters. Look, nobody called not amplified, so it needs a Christmas tree of black.
So it's amplified by our criteria over 6, HER2, and ratio over 2.
85 I have. Whoop. And then, do I have more? No. Oh, I don't have more. I thought it's another one. I'm sad already. Small. That doesn't mean small cells, but yeah.
Again, these are at least 4, I would think.
6. Yeah. Beautiful.
And you have cells with individuals included.
Do not forget with the chromosome 17 that can be big and you still count them as 1 compared with the HER2.
Yeah. So basically this one. Yeah.
Yeah, we did talk about this in the educational session. Look how nice is that one, the big cluster. Small clusters by the guidelines, it's 6, big clusters 12. But yeah, now,
yeah,
not that it matters, a case like this. We ended with this one,
yeah.
you know.
And like Simona would say, I said at least 4 in that cluster, but sometimes, I mean, they're a flat conglomerate,
Yes,
and if
exactly.
they're cut in that incidence, but like Simona said, you usually count them as 6, unless you don't see others.
We have a question by the audience or person that have done the proficiency testing. Is there a good software to automatically quantify the DDISH slides? I will pass this question to my good friend and colleague Adelina. I have no idea.
So we know people who use them. In our experience, we don't use them, but people who use them say that it's very useful for them, especially when they have like an excision specimen, because the algorithm kind of attracts their attention to the amplified. And sometimes they need to correct the assessment, but I hear that they're very happy with the counts and they usually don't need to change. But we need to make sure we have good preservation, good labeling.
Yeah, that's saying this. I'm very happy with the counting. I would be also very happy with the counting because, like, we kind of proved with our previous study, 2 quarters, we do not need to count. So if someone can give me already a count that is more or less accurate, that I know that case is negative because I can see it's negative and I do not need to state and provide a counting of 20 slides, that will be brilliant. I do think that what Ade was saying, that you need to adjust a little bit. There are those group 4 cases you need, even if you have the counting over there. Okay, you would still take it nicely, start and count, and start again, and then 20 cells and so on. Yeah. Those are the tricky ones.
I mean, and we recently have actually for HER2 a trial with the Roche automatic system, which is good in terms of kind of it gives you the precise proportion we thought, but then you need to be careful with the special staining patterns.
Yeah.
That's another point. And again, what I show you with the luminol staining, especially when you have abortive lumens or retraction artifacts, then it's very easy to go wrong with that. But I'm not saying any algorithm, they will all become much better in the near future, I would say. But they also need to be trained on the special staining patterns. And it's the same DDISH, I guess, if you have a very good and sharp, unlike some of the cases we had, because it's not always the case where you have very sharp signals, no background staining.
Oh, yes.
So you need to make sure you have very good labeling, I guess. I don't have personal experience and we're not doing it here.
No.
But yeah, there is a way. There is a way, and it's kind of annoying when you have an excision and you need to look at everything at pretty high power in order to see the DDISH signals, and it's quite daunting and annoying at times. Although we don't do it very often because it's usually core biopsy.
Lucky us.
Lucky us.
What can we say? Any questions for the participants? We are happy to answer. Or if you're shy, please put it in the chat. If not, we are telling you that we have a P16 educational session on the 22nd of October. Don't forget to register. And then, even more interesting, a fall R1 session on the 29th of October. New biomarker coming out, and 2 educational sessions. So you hope you will join us. Most probably Corrado will be around, not like now. We miss him though. Yes, and please, if you have any other suggestions, other biomarkers, please write to us.
Yeah, we might be doing them already, but we don't know if
We
how
have in the
important.
pipeline a HER2 for upper GI. It's still in the pipeline for a while because we still need to get our head around exactly what to advise to you guys, because we are also struggling. There are many tuplasis over there, and it's still surprising whoever has experience in the upper GI.
Yeah,
But yes.
And you need to understand that D-dish will be maybe for a while only, because we're moving towards HER2 expression. So in pan-tumor kind of setting, and we're going to, I think, dwell a lot on the gastric protocol, which is different from the breast. So we need to be ready for that.
We'll see. Many things that will come. Excited times. Thank you very much.
Thank you very much.